These are just a couple of different pictures that I've shown that you can see with tongues that. All right, this is just a couple examples of what you can see when we see the tongue. So, for instance, this could be an indication of a vitamin B deficiency, chelosis. Remember, we learned about that in anemia. You also need to focus here on the sides of the lips. You can see how they're cracked also and red. This is a black furry tongue. The tongue then is not shedding. So it's not shedding. So our tongue sheds. It keeps its normal color when it doesn't shed. This is what can happen. This is not common, but it could be an overaccumulation, for instance, of a bacteria or maybe even of fungus. Okay, so next we need to focus on the abdomen, okay? And you guys know that you can inspect, auscultate, percuss, and yes, you can palpate the abdomen, okay? So when you're checking the abdomen out, you want to inspect it. You want to look for, is the skin intact? You want to look for the contour of the abdomen. You want to make sure, as far as contour, we're talking about, is it flat? Is it convex? Is it concave? Is there anything protruding? Is there distension? You want to make sure that the skin is intact. You want to look for any dilated veins or the venous pattern over the belly. And you want to make sure that there's not an aortic pulsation. You can auscultate. You guys understand auscultation of all four quads. You know that you have to listen for at least 2 minutes if you're going to determine it's a silent belly. You can percuss, okay? The purpose of percussion is to just, estimate what's going on underneath. Is it fluid filled? Are there masses? Is it air? Sound waves that you percuss actually depend upon what's going on underneath. So for instance, air produces a higher pitched hollow sound, and this is termed tympany. So air produces a sound called tympany, okay? Then you can also have what we call dullness. You can percuss dullness, and dullness is produced by fluid filled or masses under the belly. Fluid filled or masses. So that produces dullness. It does talk about in your book percussing the liver and the spleen, but this is done by advanced practitioners. Next, we move on to palpation. You guys know to palpate all four quads. You can palpate the liver and the spleen, but again, this is done by the advanced practitioner. We can palpate for rebound tenderness. Rebound tenderness suggests inflammation. So rebound tenderness suggests inflammation. The technique for rebound tenderness is that we will press firmly and slowly over the side that the patient says is painful, and then we will quickly withdraw our fingers. And this can produce rebound tenderness because of inflammation. Be aware, it can also lead to increased pain and muscle spasms. Your book also then goes on to describe an assessment of the rectum and the anus, and this is on page 877. This would not be part of a normal GI exam, only if there's issues, and doing a digital rectal exam would be done by an advanced practitioner. This is a great picture that just kind of breaks the abdomen into the different quadrants. Very similar picture can be found in your book on page 875, and saying, hey, if a patient is having some issues in these particular regions, it's giving you some mere suggestions of what could be going on. I also want you guys to focus on page 878. This is showing you assessment abnormalities of your GI system. It's an excellent page. What I find problematic about this page is that there are probably a lot of medical terms on this page that you're not aware of at this point that you're going to have to take the time to learn. As I'm going down the page, for instance, make sure you understand what dysphagia is. This is under the esophagus and stomach. Do you know what hematemesis is? Do you know what dyspepsia is? Going on down, do you know what a brewery is? Do you know the signs and symptoms of hepatomegalia, splenomegalia? Do you know what melena is? This is on the very bottom. So go through this page and make sure that you understand the various medical terms that are on this list, and if not, I would recommend that you guys make up cards because there are a lot of different medical terms that could be utilized in test questions from here out that you would need to understand. Okay, we're on page 879. We're going to start talking about some of the diagnostics. There's a lot, so we're going to focus on the ones that are more common that you're going to hear about. We have upper versus lower GI series, and these are what you guys hear called the barium swallow, which is upper. So the barium swallow is upper, and then the lower GI is called the barium enema. So in both of these, the patient's getting a contrast, which is barium. Okay, so in an upper, the patient swallows it. In the lower, a patient gets a barium enema. Both of these, the patient is MPO prior to the test. They're going to have this barium substance. They're either going to swallow it, get it in the form of an enema. Post-op, extremely important, the barium has to come out or it can cause impaction. So lots of fluids and possibly stool softeners and education, because these are done on an outpatient basis. So we need to make sure the patient understands lots of fluids, stool softener, make sure the barium comes out. A cholangiography, we need to take a look at the gallbladder and the hepatic and biliary ducts for some reason. And so the one that's done most frequently is what we call a surgical cholangiogram, in which there is a contrast injected and it just highlights the gallbladder and the ducts. Often this is done when a patient is having a gallbladder removal, mainly just to make sure there's no stones any place that they shouldn't be. Flipping the page. Nuclear imaging scans. In general, nuclear imaging scans, a radioisotope is injected and highlights whatever organs that we would like to take a look at. And so for nuclear imaging scans, you tell the patient you're going to be MPO, you're going to have a radioisotope. It's not enough to hurt you, but you should only have one nuclear imaging scan per day. Gastric emptying scan. In a gastric emptying scan, the patient actually eats an egg that has been injected with this radioactive isotope, and then they take pictures of it at various intervals, and we're looking to see how quickly the stomach empties. A HIDA scan, we would like to see what's going on mainly in the liver and the gallbladder. It does get a little bit of the small intestines, and so here the patient actually gets an injection of the radioisotope. Next, we have our scopes. You can have an upper endoscopy or what we call an EGD. The EGD actually stands for esophagogastroduodenoscopy. So you can see clearly the scope is going through the mouth, down the esophagus, and takes a good look at the stomach, and then if they want to, they can actually flip into the beginning portion of the small bowel. This patient prior to is MPO, okay? They go down to the endoscopy suite. They will actually have their throat sprayed with a numbing substance to depress the gag reflex so the gag reflex is not intact during the procedure. They also will receive IV sedation. Very quick procedure, can tell us if the patient, for instance, has any bleeding in the esophagus, any esophagitis, do they have a hiatal hernia, what's going on in the stomach. Is there any gastric ulcers? Is there gastritis, gastric tumors, esophageal tumors? The patient comes back, you need to monitor them. They need to remain MPO until the gag flex returns. MPO until the gag flex returns, and then really you should give them a sip of water to make sure they can feel the water going down. You also need to monitor their vitals because they've had sedation. A lower scope is a colonoscopy. A colonoscopy goes through the rectum, and you can see it can go all the way around the large intestine. So this preoperatively requires an extensive prep. There are a different couple of types of preps, but the main thing is that when the patient comes in for a colonoscopy, you need to realize that they've had a prep. They could possibly be dehydrated and have electrolyte imbalances. You also need to ascertain that the prep was successful. What's coming out is essentially a clear liquid, no solids. We can look for and identify a lot of different things. We can polyps, ulcerative colitis, ulcerations, colon cancer, rectal cancer are some of the different things that can be identified. Post-op, the patient can be quite gassy. You need to encourage them to just go ahead and pass the gas so they don't develop abdominal distension. They could have a little bit of bleeding if biopsies were taken, and the same goes for an upper endoscopy. Once again, they've also had sedation, so you need to monitor them.